Hello, and welcome to today's webinar, a 2025 update on the pathologist's role in breast cancer treatment. I am Dr. Barbara Malkus, Board President for Massachusetts Breast Cancer Coalition, and I'd like to thank you for joining us today. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I am pleased to welcome today's speaker, MBCC's medical advisor, Dr. Michael Misialek. Dr. Misialek currently serves as Chair of Pathology at Newton-Wellesley Hospital, Newton, Mass. He is the medical director of the Vernon Cancer Center, chemistry laboratory, and point of care testing. He practices in all areas of pathology in a busy community hospital. Holding an academic appointment at Tufts University School of Medicine, he regularly instructs medical students and pathology residents. Dr. Misialek also serves as MBCC's medical advisor. Welcome back, Dr. Misialek.
Thank you very much for that kind introduction. It's a pleasure to be back here and sharing with our members, guests, audience, a little bit about pathology and what pathologists do. I give this update every year and try and select something a little bit novel, new, interesting for the public. And the common theme that runs through it every year is what I want to have folks come away with is what is a pathologist? What does a pathologist do? Whether you know it or not, a pathologist is involved in your care no matter what happens to you at a hospital. Even if you just come in and get some blood work, there's a pathologist behind the scenes making sure those instruments run appropriately, are accurate, precise, delivering results that your team can use to coordinate your care. And that goes beyond just blood testing. It involves anything that comes out of a patient's body, off of a patient's body, that's biopsied, that's cultured, that is taken out in the operating room. And for breast cancer, that's a big part of our practice. We see a lot of needle biopsies, stereotactic biopsies that happen in radiology, where the diagnosis of cancer is first made, and that's done by the pathologist. And that sets in motion the entire care algorithm for what happens next with that patient, depending on some of the prognostic markers, the type of cancer, and next steps, which are often surgery, lumpectomy or mastectomy. And the pathologist is again called into care at that point to evaluate the entire specimen and come up with a cancer report that is used again to guide the patient's treatment. And one of the most exciting things right now happening across the world is AI, artificial intelligence, and pathology is one area that is being affected by this. And that's what I wanted to devote the next 45 minutes or so to talking about how we're beginning to use AI in diagnosing breast cancer, in predicting some of the prognostic markers that affect patients' outcome, response to therapy, and contrast it with what we're doing now and what the future state may be. So let me just pull up my slides here and we'll get started. Right now, the way that pathology is practiced is, and this part doesn't change. We're always going to need a doctor, a surgeon to take out diseased tissue. That makes it down here to the pathology lab, and this is one of our assistants, a shot looking down on a breast specimen, and he's inking it here. This is actually a mastectomy, and he's putting ink down there because that's one of the things we will examine as a pathologist and put in our report is the relationship of the tumor, of normal tissue, to the margin. And the margin is determined by this ink, because before we cut into something, make any sort of introduction of the blade into the specimen, we want to make sure that we know what the true margin is, and that would have the ink. Next, as I mentioned, we will slice a specimen and start to examine it grossly and look for areas where there might be an abnormality. Oftentimes when we get a specimen such as this, we'll have some sort of landmark to look for. During radiology, during the biopsy that preceded this, they often will place a clip, and it's a metal clip, various different shapes and sizes of those, and we can image this down here in the lab, do an x-ray on it, and find where that clip is, so we can look and find exactly where that tumor is, and describe how far it is from margin, how big it is, other associated features that you'll see how we come up with those when we look under the microscope. The next step in that, after we slice the tissue, is we take little sections, smaller sections, and we put them in these what are called cassettes, or plastic containers that hold quarter-sized pieces of the tissue. And you can see some of the ink here. This is what a tumor looks like just with the naked eye. Here's another piece of tumor, and here's what it looks like after. I'll show you the next step when we introduce some wax. But these pieces of tissue are carefully dissected out. They are described in great detail in the pathology report. There will often be a section in the pathology report that says gross description, and that's our eyeball looking at the specimen without use of the microscope and just describing the gross, meaning the macroscopic appearance of a tumor, the measurements, the weights, how it relates to other tissues within the breast. And this is all without use of a microscope so far. We're just macroscopically mapping out the size, the extent of the tumor, and getting it ready for examination under the microscope here. And that tissue is then loaded. You'll see there's a lot of cassettes here. Each one of these cassettes will translate into one slide. And there's many different patients here, different cases. Each one has a unique accession number with most likely a barcode here that allows us to safely track the specimen throughout the entire process of slide preparation. After overnight processing by that tissue, the next day, those cassettes are opened back up and filled with hot paraffin here, wax. This is just wax that is dispensed into the cassette, and when it hardens, the tissue that we've dissected is fixed within that paraffin block, and that serves as a matrix so that we can handle it, and in the next steps here, put it into what we call a microtome. This is a small cutting device. You can see again this cassette with the paraffin block of tissue in here, and hopefully this will work. It's an animation, but it'll show you what our skilled technicians do in the histology lab. They'll cut this tissue. Each time it passes through, it cuts about a 5-micron section of tissue, which is extremely, extremely thin. We place it into a water bath here so that it can be manipulated, and each one of these cuts can be spread apart, floated in the water, and then you'll see with a slide there that they catch the tissue and go to the next slide. Then load it onto a glass slide here, of which the next step will be it gets stained. It's still not yet ready for looking under the microscope because we don't have any dyes in there to contrast the tissues and to look at it under the microscope. So we need to put it through what's called hematoxylin and eosin stain. This is an automated process where a number of slides all at once are dipped through a very closely sequenced arrangement of differing varying concentrations of alcohol, xylene. The slide's clean. It's then placed into hematoxylin, which is the purple stain that I'll show you some images of, and then eosin, which gives some of the pinks and reds to the slide. And it's further developed, and it comes out as a slide. And these are delivered to pathologists every day across the country in hospitals and labs. This is how a diagnosis is made of something that's removed from the body, whether it be a small biopsy, something you might go to the dermatologist, have a mole removed, same exact process. It will get turned into this glass slide. And in a breast cancer, it's not uncommon to have perhaps 20, 30, 40, 50, even 60 slides of one patient. In fact, I can talk about this a little bit later, but one nice option we offer patients here at Newton-Wellesley Hospital is when they come into their multi-clinic, where they meet with a surgeon, they meet with the oncologist, radiation oncologist, nurses, other patient navigators. They're offered the opportunity to meet with the pathologist and bring their path report over and sit down with the pathologist at the teaching scope and look at their slides. And one common theme I've seen just recently, a couple weeks ago, I had a patient, and I put down these, not just one of these, but I think there were 3 or 4 trays full of slides, and they couldn't believe that that was all their tissue. And to see, it's really eye-opening, the amount of work that goes into generating a pathology report. It's not a lot of things that patients are privy to see, but we love explaining, teaching to patients, and it really makes her a more educated patient who's able to ask thoughtful questions of the care team and be an appropriate member of shared decision making, because I think you need to understand every line of your path report in order to make informed judgments about what treatment algorithm is right for you. Every cancer is different, even though they may look the same under the microscope. As we'll see getting a little bit further into the discussion here, is that one of the things pathologists try and figure out is why cancers that might look the same under the microscope turn out to behave very differently. One cancer may turn out to be very indolent and completely cured, where another one may have a more aggressive behavior and be more apt to recurring, relapsing, or spreading further into lymph nodes or distantly. And that's one of the things that pathologists try to predict in some of the features that we measure that get reported in the pathology report, as well as some of the additional testing. And that's where AI comes into play a bit. And I'll show you how that all works here. Those slides are delivered to a pathologist. And as you see here, these trays, they hold 20 slides each. And this is not uncommon for a pathologist to get a large stack of a couple hundred slides every day to go through and diagnose 30, 40, 50 patients a day. It's a specialty that is kind of behind the scenes. I love explaining it to patients about what we do. It's not just looking at the microscope. It's certainly not what you think of as a pathologist. If you've watched TV shows such as Quincy or CSI, we're not sitting just doing autopsies all day. We're actually working with specimens from live patients who are being discussed. We're part of the care team that presents these patients at tumor boards, that participate actively in discussions about patient care, next steps, and works collaboratively with our multidisciplinary colleagues to develop the best care plan for each patient. As I mentioned, no two tumors are the same, therefore no two treatments are going to be the same for a particular couple of patients. Everyone is unique, and we're trying to find out what makes that tumor for that patient unique and different and might respond well to particular therapy versus another patient. Why artificial intelligence? One thing is that it's a significant workload for patients. As you saw that when pathologists there looking at a couple hundred slides every day over and over, that can be a lot of work. And there's certainly a number of repetitive tasks that we do as a pathologist that could benefit from assistance from AI that makes the job easier. There's also a significant amount of gray zone. Pathology is probably one of the biggest specialties where it's not just black and white. We don't look at a tumor under the microscope and say this is malignant, it's benign. There are a lot of shades of a potential malignancy or pre-malignant that fall in that gray zone within the spectrum. And part of our job is trying to sort out which of those gray zone areas is something a patient needs to worry about, something the care team needs to act on, how quickly should they act on it, and are there any therapies to stop that from progressing to cancer. As I mentioned, there's a lot of tedious, repetitive tasks as a pathologist that could benefit from AI helping some of those procedures. Biomarkers, in particular for breast cancer, the main biomarkers that we assess for are estrogen receptor, progesterone receptor, and HER2 protein. And each one of those can predict a chemotherapy regimen that will most effectively combat that particular tumor. There are a number of other biomarkers that are in use and others that are in the pipeline on the horizon. And AI is a very powerful tool to quickly evaluate a whole cocktail full of biomarkers at a pace much quicker than any pathologist could do. These tasks are time-consuming, labor-intensive. They can also be subject to inter-observer variability. One pathologist may read something slightly different from another patient. They may score a estrogen positive tumor slightly different than another patient, another pathologist who might call it weak. Another one might say moderate, 50%, and somebody else may think, well, it's closer to 75%. I think it's stronger. Those decision points, they may seem minor, but they do matter. And they do translate into adjustments on chemotherapy. So we want to have reliable data that can be repetitively repeated day after day, patient after patient, in a manner that we have a high confidence in. There may be tumors I look at one day, and then another day I may look at it and see something slightly different. So not just between pathologists, but a individual pathologist may call the same tumor slightly different at a different time of the day or over a different day. AI is certainly used in industries outside of healthcare. We've seen it used in entertainment, real estate, retail, travel, the banking sector, manufacturing, food, tech, logistics, transportation, and healthcare certainly isn't left out of that tree of uses here, and it's finally percolated down to pathology. So why has it taken so long? We've been talking about AI for a number of years. It's already in use, and things like Amazon, when you're ordering or even just browsing products. There's an algorithm running in the background that's optimized to know what your search history is and your purchase history, and being able to suggest products that you might like. And certainly advertisers have taken full advantage of AI to try and market more in a targeted manner. So why is it taken so long to get to pathology? First of all, it requires digital pathology. And what that means is what I showed to you, those first few slides of how we make a slide, take the tissue, turn it into paraffin, slice it, put it on the slide, and stain it, and look at it under the microscope. That's all traditional pathology. That's how pathology has been practiced for the past 200 plus years, 300 years. And nothing is fundamentally changed with that practice. We still have a microscope. We still look at a slide. The microscopes may have advanced some, but it's still fundamentally the same practice that our medical ancestors did hundreds of years ago. Digital means that now you take that slide and you digitize it, turn it into an image. And by doing so, you now can quantify, you can capture, you can analyze, and develop a data set of different tumors from different patients across different ages and compare outcomes with what the images look like. And suddenly you can start to harness at scale data sets that previously were unavailable just by going from a glass slide. The problem with getting to digital pathology is it's extremely expensive. You may recall radiology. Years ago, radiologists would take an X-ray and it would turn into a film, and you could take that X-ray and hold it. They'd look at it on a light board in their office, put it up there, you could see your broken bone. That's gone away. No more films. If I walk down to radiology, there's not going to be any film down there at all. It's all digital. When the instrument, the X-ray, whether it be a CAT scan or MRI, it takes an image and it immediately digitizes it, and it's online. Pathology, it's tough to get rid of the slide. We basically can't get rid of the slide because you need the slide to make the digital image. So the business argument for digital pathology struggled for a number of years because we weren't looking at removing a step in the process. We're actually adding a step. Radiology could say, okay, we're getting rid of developing film. We no longer need to buy film, develop film, have processors for that. We'll just go straight to digital. With pathology, you still have to make the slide. You still need the infrastructure, the man force to do the staining, the cutting. All of that has to stay in place. And on top of that, you have to introduce now scanners, which have just recently started to come down in cost. The other cost prohibitive factor early on in digital pathology was the amount of memory that is required to store these images. It's on the terabyte range per slide. And remember, I mentioned some patients could have up to 60 slides, and that 60 terabytes of memory is pretty substantial. And then when you look at, well, that's just one person, how about the 50 that each one of us are looking at every day in the department, the hundreds that come through here, the 30,000+ that we have just in this one hospital, not to mention go downtown to an academic medical center, Mass General, the Brigham, where they're in the hundred thousands of slides. That's a lot of memory, and that is fortunately coming down in price too. And we finally have sort of reached that tipping point where the cost of the hardware, the capital expenditure of purchasing the instruments, the scanners, the digital storage, the memory has reached a point that now the cost argument starts to make sense. And fortunately so, that's great, because now we can fully transform into a digital practice, which means at some point we'll no longer use a microscope. It will simply be viewing images on a screen, much like the radiologist does now. They've gotten rid of that film. We'll be getting rid of the slide and looking at the monitor to focus, to go into high power, and even do our stains and ordering and creating a report. That's all going to be facilitated, assisted through digital pathology. But that first step towards digital is what has been the bottleneck up until this point. So once we have digitized slides, we can develop a library of different tumor types, different tumor grades, different tumors across the body, across patient types, and start to develop some predictive models. And for instance, this would be an image of a cancer that I'm looking at under my microscope. Here are clusters of tumor cells, and in this particular type of carcinoma, they secrete a lot of mucin, so we would call this a mucinous adenocarcinoma, and this is the background breast tissue. Now, this would be an obvious tumor for a pathologist, but there are certain cases, as I mentioned, the gray zone, where it could be hard to identify the tumor when there's a lot of background inflammation or other obscuring features. And using AI and other algorithms that are in development out there, I'll just show you real quickly what this looks like here. We could take AI here and create a heat map. And you can see now we've programmed it to focus in on the areas where there's cancer. That would be the red, and it sort of fades off the proportion-wise as to where the boundary is here between benign and malignant. So that would be a use where you're helping the pathologist, instead of scrutinizing really hard, looking at under the microscope, eye strain, you're assisting now the pathologist at even low power to focus in on particular areas of the slide that are more likely to harbor a cancer. That was an invasive cancer. Here's an example of an in situ cancer where it's ductal carcinoma in situ. That's clusters of tumor cells here, and they haven't yet breached or broken out of this basement membrane around here that's enveloped it. And this is a completely in situ, hasn't spread, completely curable, 100% through surgery. This one has some calcifications. Calcifications are one of the signs that the radiologist will look for on a mammogram to point towards a suspicious area that might require biopsy. And once again, there are going to be areas that are gray zones between benign or DCIS, where we try and struggle sometimes to figure out, is it enough for cancer or is it benign? And in this case, we could use that same technology to create a heat map over here and figure out, oh, okay, that helps me as a pathologist. That looks more like a ductal carcinoma in situ rather than an atypical hyperplasia or even a regular hyperplasia, something completely benign. And these tools are far into development and even being used in some practices already. Definitely not widespread, but this is where the field is going towards. We can also look forward to AI towards helping us grade cancers. And here's a low power view of a breast cancer. And the green circles here are mitotic figures. Mitotic figures are tumor cells that divide. And why is that important? It's important because in general, tumors that have more mitotic figures are growing faster, they're turning over quicker, and they have a potential for a more aggressive behavior. So the number of mitotic figures factors heavily into how a pathologist will grade a cancer, whether they call it a low grade, more indolent cancer, or is it a high grade, more aggressive cancer? And then there's the intermediate grade. As one would expect, there's the spectrum of changes throughout. And we can go into higher power and actually see those mitotic figures much better here under higher power. But sometimes they're hard to find. When I'm searching under the microscope here, I may struggle with, is this just debris? Is it pieces of cells that have broken up? A lot of times tumors, when they grow very quickly, they can, portions of them can die. That's called necrosis, and it may be difficult in areas of necrosis to accurately discriminate a true mitotic figure from just some debris of a degenerating cell. We can use algorithms here, AI, to help identify reliably mitotic figures and help the pathologist in correctly grading a tumor. We can also look forward to AI in helping us find lymph node metastases. Cancers, all cancers, not just breast cancers, are staged. And I think everybody's aware that there's lower stage, higher stage. Higher stage usually implies a tumor that has progressed some, either locally advanced or distantly spread and advanced. And that's another job of the pathologist. The pathologist is tasked with oftentimes looking at many lymph nodes, and one can sometimes equate it to looking for a needle in a haystack. Can you find those few tumor cells that have escaped beyond the confines of the breast, of the main tumor, and perhaps gotten into the lymphatic system and spread to the closest lymph nodes, which in the case of breast are usually the axillary lymph nodes. And oftentimes it can be difficult to find just a few tumor cells or even a few small clusters of tumor. And I'll illustrate one example of how we can use AI and digital pathology. Here's a low power image of a lymph node. There's some surrounding fat here, and the algorithm has mapped out areas that would be of high interest for a pathologist to zoom into under higher power and see that, okay, there's a cluster of cells here that looks suspicious for a metastasis that's different from the background. And in this case, it's somewhat obvious, but in other cases, it can just be a single gland, less than a dozen cells, that is very difficult to accurately identify. But through the use of AI, we can highlight, target those, find suspicious areas that can direct the pathologist to scrutinize those areas more so than others. And in some cases, not particularly breast, but in some other cancers, we may have 10, 20, 30 lymph nodes to try and look through for that needle in the haystack. And AI can certainly help find that. AI can also be helpful in assessing biomarkers, as I mentioned at the top of the discussion, that in breast, we are particularly interested in estrogen, progesterone, and HER2. And how can AI help with that? Here's an image here on the left of what the stain looks like to the pathologist. This is estrogen ER stain here, and this would be an example of an ER negative tumor. And the reason this looks a little bit different than the pinks and the blues and the reds that I had shown before is because instead of putting those dyes on the tissue up front, we leave it unstained and then add the estrogen stain on top of it and develop that. And if there's estrogen, which is the estrogen receptors in the nucleus of the cell, and if that's a estrogen receptor positive tumor that's actively producing estrogen, that will develop into a brown spot. And here, you don't see any brown. This would be classified as an ER negative tumor. Here's a little bit more positivity, and this one has certainly higher positivity. AI and certain digital path algorithms can be used to help the pathologist assess that. This was where I mentioned earlier that one pathologist may grade that as negative, but another one might go into higher power and really search carefully and say, well, I think there's a hint of some brown here, and maybe I'll call this low positive, a couple percent. But with AI, we can scan that area and use some of these algorithms to more accurately count and quantify, and use image analysis to actually give an accurate reproducible score. That's much more robust than a group of pathologists, unfortunately. HER2 is another important biomarker we assess on every new invasive cancer, and it's scored as 0, 1+, 2+, or 3+ positive. 0 is negative, the 3+ is positive, and then we have the 1, which is considered negative, and 2+, which is equivocal, and we often will send that for additional testing to see if it's a true positive tumor expressing or if it's negative. These ones in this intermediate gray zone have a lot of variability among pathologists in scoring these, not just among general pathologists, but even among expert breast pathologists who all they do is read breast pathology. They can vary in these as well. And the tile of images here to the right is the corresponding digital path assisted enhancements that make scoring a little bit easier by introducing some more colors here. So these are just a few ways of using AI to help with some of the prognostic factors that we measure in breast cancer. Some other tests that we do right now, but that are on the horizon, may have heard of the Oncotype test, Oncotype DX, and what the basis of that test is essentially looking at a series of genes in a breast cancer and trying to predict what's the likelihood of relapse of that cancer if we were not to give chemotherapy versus if we gave chemotherapy. And these reports will generate a score, the risk of a recurrence, and what the benefit would be of adding chemotherapy. And they usually are associated with some curves that will look at this distant recurrence rate versus if you just had endocrine therapy plus chemotherapy or endocrine alone over time. And the oncologist will use this data to have a discussion with the patient about what their individual risk of recurrence of that tumor is over time, and whether chemotherapy is an appropriate option for that patient. And this all comes out through the assistance of the pathologist and the data that we help generate in the reports. AI, what we're finding out, and it's actually even been a few years here, 2018, this paper came out and was looking at different tumors and the Oncotype score and comparing it with what one might predict from using algorithms and AI. And there's actually programs out there that very accurately can predict and reliably assess what might be the Oncotype score just on the basis of digital pathology alone, which is quite remarkable in the sense that you're not looking at the genes, you're actually just looking at images and using data sets of tens of thousands of other patients and predicting and modeling and being able to assist in that patient's care. AI can also be used to predict some of the genetic abnormalities tumors. We can, one of the tests that often a patient may have is looking for breast cancer susceptibility genes, whether that patient has a BRCA mutation and they might be susceptible to a future cancer. That's still being done through genetic testing of DNA, but AI is actually working on using tumor modeling and being able to predict what a patient's BRCA status is just simply based on what the appearance of that tumor is, which again is pretty remarkable. Seems all great, but there's got to be a downside. So what's the limitations to AI? It all comes down to the quality of the data set that AI algorithm was developed off of. Was there any bias in those patient selections? Do they represent patients only of a certain age? Is it expanded enough that we can extrapolate that to an elderly patient that wasn't in that original data set, or even patients in different parts of the country or the world? So obviously the quality and the quantity of the data sets. Is it a data set that's just drawn off of 100 patients or 100,000 patients, which would obviously have more validity and robustness in being able to predict things? We need to validate these. Whenever we develop a test in pathology, we don't just throw it out there for use. We have to make sure that it works predictably, reliably, across different spectrums of reporting. We have to develop a range, a scoring system, and that has to be approved by federal agencies, FDA. So we don't just create a test and throw it out there for sale. It goes through strict regulatory requirements to actually make it to market, and that can be many years. As I mentioned at the beginning, digital path is really the fork in the road where that is a hard stop. And in order to get to this wonderful AI, the algorithms, we need to have pathology slides digitized, and it needs to be done in a widespread manner. And I'm glad to say that I'm in a system here where we are on our path to digital pathology, and really look forward to going along that road and getting to the destination, because it's going to open up a lot of these options here. We have to convince some pathologists. Pathologists have to be trustful of these algorithms, of machines, and sometimes pathologist trust can be one of the toughest things to overcome in this list. Not just validating and digital path, but if a pathologist is reluctant to give up their microscope, that's sometimes a hard one to change. Pathology of the future. What's it going to be like? I'm sitting here next to my microscope each day. We get slides. My colleagues get slides. We look at them under the microscope. We dictate diagnoses and create a report. There's going to be a day not so far off in the distant future where those slides won't be delivered to me physically at all. They'll be digitized and then sent through the system, and I'll be able to look at them on a monitor here, be able to use some of those algorithms we talked about to help me score some of these markers or order additional stains that I might need. I can use those images to help with tumor boards, or send those images to other colleagues throughout the system. For instance, we may have a very tough diagnosis here we struggle with, and we will send out for a consult. We'll send over to my MGH colleagues to take a look and to weigh in. And right now, what that requires is packaging up 10, 20, 30, 40, 50 slides and physically driving it over there. But with digital pathology, we'll be able to instantaneously send those images to somebody down at Mass General, or I could send it to somebody on the other side of the earth and get multiple people to weigh in at once. So this is really a defining frame shift in the way pathologists are going to be practicing pathology in the very near future. And we hope that all of these enhancements will lead to a greater, more powerful report that's going to be more tailored, individualized to that patient's tumor. And as I started off saying, what makes one tumor different from another, it's going to come down to synthesizing all this information, getting it into a report, and hopefully offering our clinical colleagues, the oncologists, the surgeons, treatment decisions that they can make in a more informed manner. And I just want to finish up here by showing you one program that is pretty exciting. It's being developed by one of my colleagues over at the Brigham and MIT, and it's called PathChat. And this has a number of fictitious patients here, number of cases, and I'll just play the image and sort of show you what's happening here. In the morning, this is sort of the workflow that would happen, is that you would get all of these slides and you could type in, review all slides and screen for any abnormality. And immediately the system can go through and look at hundreds of images across all those patients for a day and sort and say, oh, you should look at these patients first because I think there's something suspicious in there. And it can even start to order you some early stains that the pathologist may not get to until later in the day, but that the AI system has already identified. Now, this is a thyroid cancer case, not a breast, but it can certainly be used for breast. And what it's done here is it's already screened a number of slides, and I'll just fast forward a little bit here, and it's identified possibly a cancer here, and you can pull up that image and quickly go into higher power, and then begin to type in just like you would ChatGPT. And you'll see here the user is going to type in, please describe the microscopic findings that are abnormal on this slide, and just gives it a couple of seconds, and it starts to write out and confirms what we saw, what the pathologist saw histologically, that this looks worrisome for a cancer. And one can go one step further and say, okay, let's zoom into that area. Okay, this looks a little suspicious. Certainly looks like a thyroid cancer to me. Let's type in, please give a detailed differential of this area based on these regions. And you'll see, just thinking for a few seconds, and based on this, the differential is a papillary thyroid carcinoma for these particular reasons, less likely diagnosed phase number 2, number 3, and can then ask the system, okay, based on the images here, let's examine all slides of the case and what would be the most likely diagnosis looking through the whole case. And you'll see here just a few seconds of thinking and processing and considering the findings. The single top line would be papillary thyroid carcinoma. This Copilot is exactly the same type of platform that you see in ChatGPT. And then now we can go back to our list and say, okay, let's apply those findings and generate a report. And boom, there you have it. It's a report. Now, you may say, wow, that's pretty powerful. Is that going to replace a pathologist? And that's certainly a worry among many pathologists. And I think particularly so in those pathologists who who don't trust the system to give an argument of why not to adopt it. But I'll finish with a quote of why it's not going to replace a pathologist after this quick summary. So our artificial intelligence is definitely making its way to pathology. If it's not already, it's here in a lot of practices. But first, digital path is the first linchpin that has to be accomplished. It's definitely going to transform our practice, not just for breast cancer, but for many types of cancers, and not all cancers. Benign conditions, we could use these algorithms to help diagnose. It's not going to replace pathologists. And as one of the famous breast pathologists here in the Harvard system, Dr. Stu Schnitt, he says that, but pathologists who use AI may well replace pathologists who do not use AI. So his view is AI is not going to replace us, but it's going to replace a pathologist who's not willing to adopt it. And the way that I see AI is it's just another tool in our toolbox here that the pathologist can use to assist and ultimately make a better diagnosis. It's still going to require a pathologist, a human, to synthesize, to put together that report that the chat path put together may have some issues in it. It still needs a pathologist to reconcile some of the finer aspects of it and make it so there's a high degree of confidence in that diagnosis. And I believe that was the last slide. I'm happy to take any questions. Also happy to share my email address for anybody who wants to shoot an email to learn a little bit more about pathology, or even has a family member who might want to benefit from the tour of the pathology lab and looking at their slides. Always happy to answer questions.
Thank you so much, Dr. Misialek, because I was sitting and watching your presentation, and it occurred to me that AI is a great tool, but for me, in my mind, I'm thinking of the pathologist as both artist and scientist, and you still need that lens, even using that tool. So there's the great hope with that tool, but you still need to be able to have the expert who knows how to use it, and to know when AI is not, the algorithm is not working. You need that artist, right?
Yeah, that's very well put. And pathology, maybe more so than any medical specialty, is as much science as it is art, and that comes with experience. It comes with being a seasoned clinician that's seen many different tumor types, many variations, perhaps seen things that those data sets haven't seen. And that's why the human part of it will never be replaced, because that art, the art portion of pathology still requires that finesse that AI hasn't yet taken over.
I want to invite our viewers today, if you do have a question, you can put it into the question area of your menu. There's a drop down on the GoToWebinar control panel, and you can just click on that and have the drop down menu open, and you can type in your question. In the meantime, Dr. Misialek, when do you think AI is going to become really widespread in terms of use in pathology?
Great question. It's already made its inroads, and I think we've passed that tipping point there. And now we've gotten not to the business argument, but also we've fast-tracked it. I have a colleague at NYU Med who instituted all of this in under a year. And he's presenting that data at pathology conferences and sharing it with others so that we can learn from his roadmap. And I think in just within 5 years, I think many practices are going to be fully digital.
But, you know, one of the factors that impacts patients is the rising costs associated with healthcare. And you mentioned that one of the limitations to the use of AI and pathology is the prospective cost. And so is that expected to come down? Is there any way to mitigate that cost? Or is this really going to be only available in larger urban hospitals that might have the resources to be able to invest in AI technology?
That's also a great point. It still has a high price tag. I'm hopeful that it will continue to come down, but you do raise a great point about resource poor areas of the country or even the world. And there are digital path solutions that go from what I described as kind of the Cadillac system, but you can have it all the way down to just doing this with an iPhone. And now suddenly you've increased your sphere of influence and capability to deploy this type of technology to really all corners of the earth, that a cell phone could be used to scan a slide. And that's where we're going. So I'm hopeful that it's not going to be resource restricted to just wealthier areas of the world, but something that can be useful throughout.
And what about, you mentioned professional trust, and you know, you talked about the fact that many of the professional pathologists need to kind of trust the algorithm, and as you also mentioned, there's some concern about, is this going to infringe on medical need for pathologists? And so how can those factors be mitigated so that professional pathologists are embracing the opportunities that are provided through the tool of AI?
Right. One of the things I mentioned, that when you actually adopt digital path and start to explore AI, is the validation process. And that goes a long way towards enhancing pathologist trust, because each site has to individually validate it, meaning that group of pathologists will have to pull together 60 or whatever number of cases are required to scan and transmit. So they're going to actually see firsthand how well the systems function. And I think that's going to go a long way towards convincing folks. So it may not be more so a trust issue as it is a resistance to change and the inertia. And it's a hard thing to get rid of your microscope. I sit next to my microscope all day, every day. And I think that's one of the biggest changes for pathologists. And just change is tough, but jumping in and seeing how the systems work and reproducibly work is going to go a long way towards mitigating the anxiety of the change and any confidence that is associated with that. And the second part of your question about the need for pathologists, and I think as those pathologists who don't trust or are resistant to change and see how it can enhance their workflow and make them more efficient, more productive, they'll see that this is not going to replace pathologists, but actually make our job easier. And in a field where there are workforce issues, anything that can make our job better is going to go a long way towards job satisfaction and retention of pathologists, and be a plus towards the field.
I want to give you the opportunity to have the last word, but we did get a couple of questions that have come in, and if you can answer these relatively quickly. One question is, you mentioned that the AI algorithms' reliability are based on good data. As this data changes over time, is it being incorporated and changing the algorithm?
Yes, many of those algorithms are dynamic, and they do come out with updates that are based on new data sets. So yes, that's something that's not static, that's fixed. It is dynamic.
And our last question for today, how far off is AI and digital pathology in replacing mammoprint or oncotype as a more efficient and timely measure of prognostic and predictive information?
That's a great question, and I think it's not too far off. I showed a quick paper on the reproducibility of predicting that, and we're already seeing good data from it. And that's going to be a big change, because right now oncotype can be pretty cost restrictive, and there may not be insurance approval in certain off-label uses. If we're able to get AI, digital pathology, to perform as good or better even, that's going to be a real cost saver. So we've talked about cost expenses, but that would be an example where you could potentially save cost and save it in a significant manner. So I'm hopeful that that day will come.
Dr. Misialek, I feel bad that we're running out of time, because I love hearing about the latest updates in pathology. You always bring us such valuable information, and it is so greatly appreciated. Thank you.
Thank you. I appreciate the time.
On behalf of myself, the MBCC board, and Cheryl Osimo, MBCC's executive director, I want to thank Dr. Misialek for this very informative discussion today. And I want to thank all of our many listeners for joining us. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. If you would like to further support our mission of preventing environmental causes of breast cancer, please consider making a donation by visiting mbcc.org/donate. I appreciate your consideration. Have a great afternoon.